Before we start, I just want to say that this video is for teaching purposes only, and it is not intended to make any official diagnosis. I will share my opinion and perspective, but my views are my views only. They do not represent any specific university, medical school, organization, or entity. If you like this video, please hit the subscribe button below and give me some likes. That will keep me motivated to keep doing these videos. Thank you. Hey guys, my name is Dr. Anthony. I am a neurologist. And have you guys ever wondered what it takes to be an amazing medical student? Some of you guys think you already are an amazing medical student, but then you get into clinics and your attendings don't think so highly of you. So what do we as attendings really value in students? What can you do to be like the best student we've ever seen? Okay, so this video will try to give you some pointers on how to achieve that amazing student status. Okay, let's go. It seems that every single month, students and residents make the same mistakes. And that's not just from one university. That's from multiple different medical schools. They all make the same mistake. So what are those mistakes? And what can you do to avoid those mistakes? So as an attending, I think the most important trait a medical student or resident can have or learn to acquire would be communication skills. And that includes listening and talking to the patient, as well as communicating with the attending and writing an amazing H&P on the patient's chart. And in this process, most students make very similar mistakes. So first of all, let's talk about the history. So most students think they know how to take a good history and physical. They go in and see the patient. They ask the patient a few questions. The patient tells them a story. They listen to it. They write it down. They come out. And they tell the attending exactly what the patient told them in the exact order in which the patient told them. And there is no interpretation, there is no reconfiguring of the history to make a coherent story, and the attending is kind of lost at the end of that presentation. And when we ask a student or resident, did you have a hard time getting the history? The answer is, yeah, the patient was a bad historian. Okay, guys, all that is a bunch of bunk, okay? The patient is not the historian. You are the historian. Look it up. Look at the definition of historian. So from this point forward, never ever say that. Never say the patient was a bad historian. Why are you blaming the patient? Stop it. As an attending who hears that, it ticks me off that you guys don't take responsibility for your poor history taking skills. Own up to it, get better, and do a better job next time, okay? So don't ever say the patient was a bad historian. So what can you do to be a better historian? Well, when the patient tells you their complaints, their history, they don't know what is important. If they knew, they wouldn't be in your clinic. They're the patient. You're the clinician. You are supposed to take what they tell you, listen to it, interpret it, create a differential in your head, ask them more questions. I'll give you an example. Within the neurologic realm, someone comes in with leg weakness and they tell you all about their legs. And it happens to be bilateral leg weakness. and you come out and you tell your attending, well, I think it's a neuropathy. It's bilateral, symmetrical, distal to proximal. And the attending asks you, are you sure? And you say, yeah, there was some numbness and some weakness in both legs. And I, as the attending, would tell you, you just got a nice lawsuit on your hands. Okay? So why did I say that? Why do I say that's a nice little lawsuit? Well, because you didn't take a proper history. You didn't take a history of any bowel or bladder issues. Do they have groin or inguinal numbness? Do they have any truncal numbness? What was the length of time in which this started? Did they have any back pain? Okay. Can you prove to me that this was not a spinal cord compression? Because if you miss a spinal cord compression and call it a neuropathy and send them home and do some nerve conduction studies and not think about doing an MRI of the full spine, you just screwed up. Okay? History, 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 history. So they tell you it's bilateral leg weakness, but you now have to think about other things in differential, which includes spinal cord lesions. And you have to ask questions about spinal cord pathology. And if all that's negative and truly is a glove and stocking sensory loss and a distal to proximal weakness, which really resembles a neuropathy, that's fine. But you have to exclude all the other possible items in your differential. The second mistake most students and residents make is that after they take the history, when they come out, and I said this just a few seconds ago, and that is they don't think about it and interpret it and create a good story. So they just regurgitate exactly what the patient told them. So basically, you've gone to medical school, paid whatever thousands of dollars for your education, only to be a scribe. Really. So you paid all that money and you are now a scribe. Congratulations. That's idiotic. Okay? You're a clinician. So behave like one, which means once you talk to the patient, you come out and you think about your differential, think about the story, reorganize the history to make it a coherent story. And when you present the history to your attending, make sure, one, it makes sense in a chronological way. Number two, mention the pertinent negatives. So that in that example, if you have bilateral leg weakness and you really think it's a neuropathy and you've excluded spinal cord pathology, well, the pertinent negatives must be that the patient does not have bowel and bladder issues. The patient does not have numbness or tingling in the belly or in the inguinal region or the anal region. And you've got to mention these pertinent things. And those are not review of systems things. These are pertinent negatives as part of the history. Okay? And the third thing that most students and residents kind of screw up on is not knowing the difference between a sign and a symptom. This is so important. So when you present your case, the history are symptoms. Symptoms are historical bits of information the patient told you or that you were able to pull out of them. Okay? Signs are objective. Clinical signs are physical exam findings. So you don't talk about the history and throw in there the reflexes and throw in their rebound tenderness or throw in their heart findings. No, the history is the history. The two shall not meet. You present the history, then you present the physical exam, and the physical exam basically contains all the pertinent signs, and then the assessment and plan. You don't combine these four things, okay? So as an attending, when I have students and residents come through the office, what aspects of their clinical skills do I think would make an amazing student or resident? Well, number one, history taking skills, as we just talked about. If you can go in there and take an amazing history and put it together, and then second part, present the history in an organized, coherent fashion, and keeping the segments of the history and physical in its proper order, you have just impressed me. Okay, and not just me, you've impressed every attending that you're working with. Because if you can communicate properly, that tells me that you've got the chops to be an amazing physician, not just a scribe. Okay, and I really mean that. So take this to heart. And, history taking skills are not easy. Putting the whole thing together is not easy. If it were easy, you wouldn't be in medical school. This would be a 6-month weekend course, right? Come on. This is serious stuff. This is your career, life, and death is at stake here, and communicate properly. And down the road, once you get out, if you don't learn these skills now, down the road, when you dictate your note and you send it to your consultant or your primary care physician, whoever you send your notes to, and they read your sorry-ass notes, guess what? They just lost respect for you. Your note, your H&P, is the way you communicate with your colleagues. And if you cannot communicate properly, coherently, clearly, and get to the point and not just regurgitate what the patient said, if you can do that in a really well-organized way, you've just earned the respect of all your colleagues. Again, that's down the road, but you don't get there without trying hard, practicing, making mistakes, but really, really trying now, okay? So what we just talked about may seem like nebulous piece of advice. It really isn't. Really take it to heart, think about it, because if you can master these history-taking, presentation, integration type skills and practice month in, month out, patient in, patient out, you're not going to be great at it day one. The hope is it's a long-term learning process. Even after you finish your residency, you'll keep working at it and working at it. But if you can do that and people recognize that you have amazing communication skills, you will have an extremely successful career. Okay. So I hope to have you guys as my colleague one of these days. I hope you guys, love teaching the way I do and give back to future generations of students by making your own videos and teaching other medical students. But good luck in clinics. Stay positive, and we'll see you on the next video. If you like this video, please hit the subscribe button below and give me some likes. That will keep me motivated to keep doing these videos. Thank you.